There we go. Um, Chris, how long would you like your bio part to be?
Short.
So Dr. Chris Sheldrick is the director of the evaluation team for Team Up. He is going to be our moderator today. I think I'm going to just defer to the rest of his bio in the speaker section on WUVA. If you'd like to learn more about him, it's very exciting. The other kind of interesting thing about Chris is that he's one of the developers of the SWIC. So if you like the SWIC, you have him to thank. If you don't like the SWIC, you have him to thank.
No, my co-developer.
So along with the video storytelling projects that obviously we have one at the beginning and one at the end of the day-to-day, we also, this is the royal we, because again, it's really Sonia's effort and work here leading this for us, but we put together a video because we get asked a lot of the time, like, what is Team Up? And you know, kind of, I saw your model, but could you just help me understand very quickly, what is this? And so we put together a video to try to do that. So we're going to start with that video. Okay. Elijah, are you getting sound?
Thank you.
Yes, thank you for that.
Thank you.
I'm unmuted. Yeah. Could you let your colleague know that we are I'm gonna keep going, but that we are gonna try to figure out what's going on there, and we'll fix that for them on soon. Thank you. So let me first just share. I'm gonna try to do this. Now I'm just going to check a few things and make sure that our volume is as high as it can be. Hopefully they didn't hear that part, right? All right, I think we are set in a way that should be working for the remote audience. So I'm going to keep going, but we will check into that as much as we can as well. Okay, now it should also be up for the remote audience.
The world needs to move towards integration. We can all see and feel, even in our own lives, the pitfalls of fractured, fragmented care.
With so much that's unpredictable, one of the best things that we can do is really team up to try to address those things together in the long term.
I think the original vision for Team Up was to expand access to child mental health services at federally qualified health centers. There was a sense of promoting health equity and a recognition that the population served at the health centers often had difficulty accessing mental health services.
There was a deficit, kind of peer-reviewed literature that spoke to how to provide really high-quality, evidence-informed behavioral health care within the environment of pediatrics of primary care. There were not models to take off the shelf. It doesn't work to hand over a model to a health center and ask that health center to implement that model. The guiding principles of what it is that we're trying to achieve need to be the core essence of what everybody is signing on to do together.
The Team Up model really does a nice job in bringing the behavioral health side of things with the medical side of things, with the inclusion of BHCs and also with the inclusion of community health workers. The three roles together really have the opportunity to provide quality care, particularly for the marginalized high-risk population.
This kind of research is not rocket science. Rocket science is way easier. And the reason rocket science is way easier is that it's more predictable. My hope is that Team Up can be part of the solution to really shifting toward thinking about the voices of all kinds of people from all kinds of different populations in a different way, and really thinking about equity more deeply. There's not as much evidence on populations that have been historically oppressed in different ways. As a researcher, I think the clear imperative is to really deepen the evidence base so that we can say with more confidence what works for a very diverse range of people.
There's a lot of hierarchy in the medical profession, and I think that Team Up has consciously acknowledged that and recognizes it as something that needs to be addressed.
We have to look beyond traditionally trained psychotherapists, psychologists, psychiatrists, to look towards who are already existing role models in communities. The community health worker role that is part of the Team Up model is a really good example of this.
It's truly that human interaction, that therapeutic approach, and that ability to connect with families that's really truly going to make an impact on how we're delivering care and impact on the health outcomes for the families and their children.
I think it would be hard to do the work that we do without these spaces where we can do a mix of supporting sites individually and also creating spaces where people can just develop relationships across health centers.
Team Up has really been a wonderful platform, not only to directly change the experience of patients and families in Team Up health centers, directly change the experience of the healthcare team in delivering that care, but also through the learning that has happened through this initiative to work on changing at the policy level our expectations for what we would like our healthcare system to be like and how we would like it to function for all of us.
Some of the best examples of people, like the relationships that have been formed and people taking the supports that we've put in place and taking advantage of those relationships, is when I hear from practices that they're meeting together without us, and that's actually the best feeling.
I think the future is integrating mental health, well-being, therapeutic, social, emotional understanding into all of our infrastructures, into schools and into our medical care, into our workplaces, into all the spaces that we share together. The bigger picture is how to set up structures that mediate stress and burnout and sustain us in a way where we're taking care of each other.
I think a lot about the next generation.
I think that it's clear, based on my experience here, that I definitely want to be in a place where the values regarding one's wellness and social connection and belonging is embodied by the people that you're working with, and also your coworkers and your supervisors.
I hope that any number of practices, federally qualified health centers, but also private practices, large health systems, are able to capitalize on the learning and the Team Up has made. If I was to go, 10 years forward, I would hope that the Team Up almost is such an established part of how we think about providing behavioral health care to children and families that maybe it's even an afterthought. It's just taken as a standard part of healthcare.
Right, we're gonna stop there so we can go on to our conversation. For your colleague who is remote. I think they solved the problem that was in a different room, so hopefully she's all set.
Okay, so now I'm going to kick Anita out and make her join the panel, which is actually really good news because we're going to hear more from the panelists than from me. Because the goal today is to learn more about Team Up. as Anita mentioned, I'm Sheldrick. I'm the director of evaluation for Team Up. And I have to say, I'm excited about this panel because a big part of how I see my job is to learn more about what's really happening at these health centers, which, as we said in the video, is deep and rich and complex. So we're fortunate to have with us today a number of panelists who have all different roles and different perspectives on Team Up. We have Nancy Langhans, the medical director of pediatrics at New Bedford Health Center, or now retired, excuse me, and Team Up co-clinical champion for Cohort 2 health centers. We have Genevieve Daftery, who is the medical director of practice at Codman Square Health Center. I think very much not retired, as far as I know.
That's not retired.
And past Team Up co-clinical champion for Cohort 1 Health Center. We have Laura Sherman, director of local initiatives and partnerships with the Klarman Family Foundation. We have Shauna Schulman, the director of health and medical research for the Smith Family Foundation. Suzanne Curry, director of policy and government relations at Healthcare for All. Anita Morris, who you've been hearing so far, Team Up project director. Megan Bear-Merritt, who is the chief scientific officer at Boston Medical Center and was previously the co-director of evaluation. And I say prior to that, the director of evaluation for Team Up as well. So before we begin, I'm going to have a series of questions. I have a series of questions sort of prepared for each of the panelists to help walk us through what the Team Up model is. But just before we begin, I'd like to turn to you all in the audience and just to see if you have any questions. Are there particular things you would like us to highlight as we go on? And I'll show you, it won't interrupt. We'll just try to really make sure we emphasize anything that you ask about or bring up as we move on through the session. So if you would come up to the microphone, I think, if you don't mind.
That's
Hi, John Strauss. So at the beginning, there was so much focus on how we're going to pay for this. So I think we really, the model, theoretically, from Mass Health's point of view, they've changed the payment. So how do you translate that? How is that translating? So to comment on when our foundation friends not going to need to be at this table would be an interesting question.
Thank you for that.
I'd love to hear a little bit about what it's like for patients as they go through. Is it seamless? Just what's their experience?
Great.
There's a lot of BHI models out there, and I think with varying success. And so what I'm really listening for is sort of what do, after all of our experience, people see as the secret sauce of Team Up, that as we think about scaling or transferring or whatever are the things that we wouldn't want to lose because we'd be throwing the baby out with the bathwater.
Great.
I just sneak my comment to say, and I hope to see some light as an adult, as an internist, like how do we move now Team Up to cover, the parents of those children and make it a whole family.
Great. Thank you for these questions. These, I think, are questions that we think about quite a lot. Oh, we have another one. Good.
Sorry,
Excellent.
very good. A last thing is also how is Team Up coming together with the other efforts? Because there's the TPAC funding that's coming together, how we're all looking at that and the other efforts. And again, I know that they're doing a lot of great work around the data. I asked data earlier. So if you can continue a little bit of that conversation, because I know it's something that is a priority for them too. Thank you.
Data questions speak to my heart as an evaluator. So thank you for this one. But anyway, okay, any other questions? These are really great. Will help guide the discussion. So thank you for this. Okay, so to begin, I think a number of these questions are good segues. I'm going to turn to Anita first. So Anita, can you start by giving us an overview of what Team Up is and how the initiative is organized?
Sure. So I'm trying to figure out how to answer that and kind of put on some of these questions as well. So Team Up started in 2015. I think one of the core distinguishing factors of Team Up was that when Team Up started, the charge that was laid to all of us to work on was actually to develop a model. It wasn't to implement a model. It was actually co-development. And during the first phase in particular, so Genevieve's experience can speak to this well, what we were doing was really creating that clinical model. And as we moved into the second cohort of health centers in 2019, then we started to work on both implementation, so test of whether this is scalable, test of whether it works in different environments, and continued model development. So from Nancy's experience, I think she can speak to both of those. We think about Team Up as obviously kind of at its core, a clinical model. What is also unique about the Team Up initiative is the system-wide orientation, I guess, of that model, which means the model needs to be sustained. This gets to the question about revenue beyond the term of a clinic's implementation of the model itself. So the change that has to happen there has to be sustainable long-term. And so we've oriented ourselves towards that in a number of different ways. And I think ultimately Suzanne at the other end of my bookend at the other end of the table is really going to be able to exemplify that, which is that in order to make this sustainable, you have to work at the health center level around operationalizing this, getting the EMR to work in your favor, all of those kind of operational components, all the way up to the point of policy and advocacy work around making sure that it's sustainable because the whole system is oriented towards it as well. At its core, we have always seen Team Up, we said this at the beginning as well, as a health equity initiative, meaning that the core issue that we were looking at was lack of access to high quality, evidence-based behavioral health care within primary care. And throughout the 8 years, we've done a lot of work to really deconstruct what we mean by health equity and what we mean by making sure that everybody has prompt access to care. Yeah, I think I will stop there for now. Actually, I'll make one more point, which is we think about Team Up as being full spectrum, that clinical model as being full spectrum. And what we mean by that is that it's birth to young adulthood and that it is not dependent on a diagnosis. So it includes prevention, promotion, early identification of emerging issues, diagnosis, access to care, reassessment, and connection to the community-based services and to specialty care where appropriate. We don't think of Team Up, our goal in Team Up is not for a child to get 100% of all of their behavioral health needs met in primary care. Our goal is for primary care to do what primary care is uniquely situated to be able to do. We have within Team Up, Stephanie Kuntz, I don't think is in the room today, but Stephanie Kuntz and Dana Rubin, both psychiatrists or consulting psychiatrists to the Team Up health centers, to the Team Up providers. We think about the full spectrum as needing to be inclusive of community-based services and specialty level care, and that for a child to get all their health needs met, all of that has to be within the picture. And then that the team, the kind of locus of the team, is a clinical team made up of the primary care provider, a behavioral health clinician, and the community health worker. And I think that is also a kind of unique identifier for Team Up.
Great, thank you. So that I think gives a really nice overview of Team Up from a project kind of perspective. But to get a more of a perspective of what it looks like on the ground, Nancy and Genevieve, could you describe more about how Team Up works at your health centers?
So first off, I will say that before Team Up, we had no behavioral health at our health center. We're the one community health center that had no behavioral health going into this project. So it has been quite a journey and has been wonderful. I think what I'll do is tell you a little bit about how it works at a primary care visit. A kid comes in and the front desk gives them the screening tool, the parent, the screening tool, either SWIC for the young kids or the PSC 17 for the older kids. When the MA goes to room the patient, they see if the parent was able to fill it out, if they were able to read, which significant portion can't. And they will get one of the community health workers to come and help the family fill out the form. And they MAs also do the screenings for the social determinants of health. The provider then goes in and reviews all the screening. If there's been a social determinant of health problem identified, the MA has already reached out to the community health worker, because one of the things that they do is they help to connect people with resources within the community, which is really important. And one example of how that was in during the pandemic is there were people with food needs. There was something called My Brother's Keeper, which did deliveries every 2 weeks, but they only spoke English, and they 60% of our patients speak Spanish, and another 10% speak either Portuguese or Cape Verdean Creole. So they couldn't access it. So our community health workers were making delivery requests for those services. Another way that the community health workers work, if the provider sees that there is a developmental issue and the kid is still in the early intervention age, the community health worker will get a warm handoff from the provider. They will go in and meet with the parent and actually try to reach the early intervention provider at the time the patient is there. And our rates of kids actually getting early intervention, I know, have gone up. Other things, if there's an identified behavioral health issue, then we do a warm handoff with the behavioral health clinician, who will go in, and if they have time, they'll do a brief visit, or they'll just go in and meet and set up another time. And this also really helps because in the New Bedford area, our non-English speaking families were not really able to access care, because many of the providers wouldn't provide services to families whose parents don't speak English. And that has really, it's just been amazing to be able to get kids services when before we didn't even have services available for kids. And you'd have a kid who had some suicidal ideation, but you knew if it wasn't bad enough that the crisis center would have them admitted, and you felt helpless because you couldn't get them in for counseling with anybody. So it really has made a huge difference. I think we're doing a much better job of screening, of using the screening data to guide our care. We communicate, we're really fortunate in that we were undergoing a major renovation and expansion of our department at the time we got this grant. And so the CHWs and the social workers are actually physically located right there in the department. And so when I need something, I can message them or I could message them in the electronic health record, or a lot of times I just walk down the hall and grab somebody and pull them into a room. And it also meant that we don't do a lot of meetings, but we would, the behavioral health clinician or the CHW would have a concern about a patient, and they just walk into the office where all the providers sit, and we chat about it and come up with solutions. So it really was transformative to have this project at the health center.
So at Codman, we had some behavioral health services on site and in an integrated fashion, and that spectrum of integration had evolved even for us. So for years, we'd had a specialty department on site with a shared EMR for like 25 years. So some would say that's like really leading edge, and referring into that could feel like referring into something in another state sometimes, as far as wait lists and the likelihood that you get like meaningful feedback back, unless you happen to pop into a chart and see a note later. We sort of started to evolve at the time that Team Up came. We had at the time the worst named thing ever called a B-HIT, which like never say the word hit in the title of someone's name, but those were integrated clinicians who would respond. And it was, we had not enough staffing levels. So I think understanding your par levels for what you're trying to deliver is like really, really key, and something that this initiative helped us understand. So we had like 1.5 clinicians for a health center that serves 25,000 people. Insider information, that's too few. So that was functioning in a way where we were essentially only really able to access them for crisis situations, which we have plenty of that walk into primary care. So, also a good reminder, like primary care is the #1 crisis evaluation place for behavioral health issues. It's not the crisis center, but volume itself. And really what was happening was we couldn't really serve, we couldn't serve school age kids. We were sort of serving 16 and up through that service. We had this awesome project launch program that was also heavily supported through grants, and also felt like this separate little thing where they were doing their own screenings once we had identified a family in need, and carrying a pretty low caseload, honestly, for the number of young families that were coming through, and that was for up to age 8. And so when we entered the team up space, it was like, okay, we've had some practice doing a warm handoff. We know what it means to screen, although there's more intensive screening being done by this little grant group of a family partner and a clinician. Once one of us has raised our hands and said we're worried in any way about the family. And then we had this huge swath of school-age children and young teenagers who were unable to access services in primary care. And so I think for Team Up for us, it was the model of team. And I think the fact that as we were developing the program, actually the naming took a decent amount of time, I'll say, and like good iteration, but the fact that the word team ended up in there, I think is actually really important because it totally transformed what we thought of as a primary care team. And that primary care team very heavily became seated in, this is not a special program. This is not a warm handoff to the specialists that live in another part of our building. This is just like ordering a vaccine. It seamlessly should happen whenever one of us raises our hand and says it needs to happen. It doesn't need to be me that raises my hand. So there's standing orders for vaccines in clinic, right? I am not always the person that calls a behavioral health clinician to the room or a family partner. It can be one of the medical assistants. I think our nurses reach out to our behavioral health team because of phone calls, probably more regularly than I might in a visit in some ways because of what comes in. So I think we really reached a place where the patient experience is, I reach out to the care team with a concern. Oftentimes the first point of entry is call center, nurse, call. If you're in person in a visit, it might be myself, and you might not feel comfortable saying something to a medical assistant. The tool is there. Certainly the screener is there to be a proactive flag for me. Quite frankly, people usually speak up before that or in their own way. And then we find a connection to the person that's going to best suit your needs. We're able to do warm handoffs. We're able to do lukewarm handoffs through the EHR when we're doing telemedicine through our chat, and have someone call you that same day. It can be a case manager who's referring out if we understand that our services at the health center aren't going to meet your needs. It can be a family partner who's going to help support you and navigate you through something really hard going on at school, setting up a 504, setting up an IEP, advocating for one of those things that isn't functioning right now, whether it's around special ed services or behavioral services as part of your special ed plan. And so I think that that concept of like the team is just totally different. What we consider the team to be is now this really expansive version. In the best of times, and this is sort of like where workforce has shifted, I think a bit because of the pandemic, and then a bit because of the other amazing behavioral health services that we're trying to provide across the state that are sort of stretching things, I think a little lean right now. Best of times, we were like truly teamed up to panels. So meaning I was consistently working with the same clinician all the time, and so was 2 of my other colleagues or something like that. So we were getting like really into that level of top health management. That's a lot harder with some of our workforce dilemma right now. So we've gone back to more of pooled resource. There's some benefits to that too. Someone asked the question, I think Anita brought up, like, you know, what do we do about adults? Actually, everyone's a generalist now. At a community health center, that's actually really helpful. So in some ways, I have access to more clinicians than I used to, because we've sort of, all of our clinicians are taking on adults and kids at the very least for warm handoffs. And I think that's really an important thing that we can now provide. And I don't know that we would have been able to do that. I think Team Up gave us the confidence to kind of spread some of that education.
Great, thank you both. I'm not going to let you off the hook quite yet, though, because we have another question. I think a big theme of this morning was about the importance of engaging with lived experience and paying attention to things like patient satisfaction. And, you know, immediately a couple of questions from the audience were really about what is the, you know, what's the patient experience? What's the experience of parents? So I'm wondering if you can say a little bit more about what you think about the impact of Team Up for the patients and the families that you serve.
So I could say, I can give a couple of examples. So during the pandemic, all our community health workers were working from home virtually. And one of the things they were doing is they were administering the SWIC over the phone to people. And as any of you who know the SWIC know that up to age 6 months, there's a screener for maternal depression. And we had a couple of times where it was a very concerning result. And they worked it out. So they got one of the behavioral health clinicians to come in to speak with the mom. They actually got the mom sent to the hospital where she was admitted because she was very close to committing suicide. So that's one example. I can't, another way in which the team works is I had a patient myself who was living with her dad. Mom was out of the picture. She has some vague SI kind of thinking, but not where you really thought she was going to follow through. And I spoke at length with the teen and her dad, and I thought she probably should start on medicine fairly soon, but dad was adamant that he didn't want any medicines. So we did a warm handoff with a behavioral health clinician who met with her, I think maybe 3 or 4 times before she said, like, it really needs meds. And so we were able to set up a time when both of us could meet with the dad and the patient and go through all of it, go through the risks, go through the benefits, go through why we thought it would be a good idea. And dad finally consented to having her go on medications. She went on medications and she did quite well, and eventually was able to wean off the SSRI, which was really fantastic. So that's kind of, I mean, it's, like I said before, our patients were not able at all really to access services. And it just is to have that level of people caring. I think you know, when they talk with a community health worker for the referral to EI, I think the community health worker, because they're from their community, they understand the issues parents have, why they were never following through, and which I think is one of the reasons why we have, you know, more kids are getting EI, is because our community health workers are the ones who are doing the referral and actually helping to explain what it's all about.
I think families are just experiencing that sort of like full spectrum of care that allows them to be more open to engaging with behavioral health services when and if the need comes up. So, you know, much like Nancy described, so our family partners are trying to meet families early on in what we call like preventative touch, where they're doing Boston basics, or sometimes not even that, sometimes literally going in and introducing themselves as part of the care team at baby visits and checking in on parents. And so it's done in this sort of like, hey, I'm part of the team too. You're meeting me the same way you're meeting your news provider for this kiddo. I'm around for this if you need me, and I'll probably pop in a couple times in the next 2 years to say hi to. They inevitably end up seeing them again for a basic resource need, or even something as simple as like navigating a daycare and preschool. And then when things come up, I think the difference of what families are experiencing now is just so much more sense of support and help with navigation through something that is challenging. Like at the end of the day, I get confused sometimes about how to access some of these services for my patients, right? And so if I'm confused, what we used to do before, where we said like we would try to take care of this. Here's this list of amazing resources in the community that you can call and try to get on a wait list or access services. You can try to describe what's going on. You know, we do a lot of work with families on like how they would communicate in that call, what it was that they needed. That's like just really hard for people. And you put in a couple of social determinant barriers and I think it becomes nearly impossible. And so now there is a family partner to be alongside you in that, not to necessarily do the whole thing for you, but if you say that's actually what you need them to do, that is okay too. But to really be alongside someone navigating through that system, either internally, because it's still like a warm handoff, maybe someone's coming into the room, meeting you that day, but you have to schedule a follow-up appointment. And now someone's going to kind of be there to reach out and make sure you do that. There's a ton of psychoeducation that I think is happening now that didn't used to happen as well before. So we're spending time for 3 to 5 visits with someone who may actually end up needing quite a higher level of services, but the likelihood that they connect with those now is way better than what we were doing before. So I think it's just a real sense of support, navigation, holding until families are ready for what we're recommending or what they're speaking up that they need. With a lot of family centricity to this too. I think like we've really been able to focus on parents and kids in this model, because the clinician may ultimately be focused on the child, but that family partner is there for the parent and maybe connecting the parent with their own clinician when the need arises.
Great, thank you so much. This is incredibly helpful. I'm going to segue a little bit because remember, Team Up is a big project. It has a lot of different components. So to get a very different perspective that keeps coming up, I'm going to turn to Megan. So Megan, you were with Team Up since the very, very beginning, part of its inception, launched the evaluation team, authored the evaluation plan, and directed it for many years. And I've been so happy to work with you on that in the latter stages. Could you say something about the role of the evaluation team on Team Up and its function and something about the findings to date?
Yeah, absolutely. So just a moment, so this feels like, not that I ever left because I said I needed to stick around, but it feels like coming home. And, it's been 8 years. And I think the wisdom of all of the people that have come together to create this initiative is just, feels so exciting to see where we are in this moment. I will tell you, Genevieve was talking about the name of Team Up, so I will give you a little known fact. You'll be very glad you came to this session versus others. Going back to the inception of Team Up, sorry, this is not your question, Chris.
That's part of the thing.
The name Team Up, we were not always Team Up. The name Team Up came from actually one of the evaluation research assistants in a car ride with Shauna, going back from Lowell. It was our old name was CBHI, which was a little bit, nobody was that excited about it. CMHI.
It's very confusing because of CBHI.
Exactly. Nobody was very excited about it. So from the evaluation, not that's what we were tasked with, but one of the research assistants was like, how about Team Up? And hence the name came forth. So evaluation had many roles in addition to actual evaluation. So, I think one of the things that we've heard a lot is this idea of field building. And just as I think when we came together, there was not a comprehensive integrated model for kids and kids served by community health centers. There really wasn't an evaluation framework either. We were doing a lot of field building in the space of evaluation. And so, we really thought about the evaluation is like, how do we both prove and improve the model? Prove the model, give the data that is needed. I promise I did not have a conversation with Mary Lou Sutters. I did not pay her off. It did make my day and my week and my year to hear her say, like, we can take the data from Team Up and use it to advocate for integrated behavioral health for children across the Commonwealth, for children across the country. And so to that, how do you prove the model? We undertook things like leveraging claims analysis because we're able to get claims from kids across the state. And with that, are able to look at how kids in Team Up health centers fare as it compares to kids who are in health centers, but health centers without Team Up. So looking at, and Anita shared some of the findings, but kids in Team Up health centers had more mental health-based primary care. They had fewer, they had less polypharmacy, which we always worry about for psychotropic medications, and it did not increase cost. Similarly, what's been discussed here, a cohort study, actually talking to patients, what does this mean to you and to your well-being over time, and looking at that impact. And so, really thinking about how does this change outcomes for kids. At the same time, we really wanted to be able to work hand in hand with CHCs and the leadership there to be able to think about how does the model evolve, and to do that, to be able to provide data. And data as close to in real time. It's not always in real time because electronic medical records are not always nimble, but to really think about and improve your model. And so looking at, as an example, screening rates over time, and what does that look like, and what are the changes, and then what are the changes you want to make. So we're able to look at screening rates and screening rates by site, and then put that into a process map and what we call a failure modes analysis. So, where are the places where screening may, I don't want to say go wrong, but like maybe in jeopardy? And then how do you gird those systems in a way that's meaningful for you and for your health center? Later in the day, we have a session on looking at race, ethnicity, language. Like, does this model of care operate differently for different populations of people within health centers? And then how can health centers take that contextual data and say, like, this is how we think we need to change. It's not our role as the evaluation to say, this is what it says, so do this. Like, what does this data mean to you? And so, I think that evaluation has been core. Many of the metrics, actually, the last thing I will say, were built in partnership with particularly our cohort 1. Health centers evolved in cohort 2. One of them I'll mention is this idea of a behavioral health plan. Like, we realized we wanted to understand what happened, and this has expanded, but back in our first, in 2015, 2016, when primary care providers were interacting with patients, what were the decisions they were making around behavioral health care? And there's no way to understand that in the medical record. And so co-created a way to template it and document it and be able to pull it out to feed into that prove and improve model. So I guess, I think we've learned a lot. We continue to learn. We continue to hope to build the field to be able to spread the model, and also to help locally the CHCs own their data and make changes based on their data. And, I think part of this really was, it's deep thanks to the foundations. They have really invested substantively in the evaluation to do this work and to move as the practice transformation moved hand in hand with that. And I think it's been really instrumental.
Well, thank you. And that's a perfect segue, because again, this panel is all about getting very different perspectives on Team Up. So thank you for that overview of the evaluation. I'd love to turn to Shauna and Laura now. And as representatives of our 2 funding partners, I'm wondering if you can say a bit about the strategic decisions that you've made around funding that have shaped the core partnerships within the Team Up initiative.
So that all takes money and a lot of time and investment. And we knew as community health funders that our community health providers were full of good intention and commitment and devotion, but they didn't have time to think about this in the course of their busy day. And so in the very beginning, the foundation sat across from people, well, we sat across from you, Genevieve, who in her role leading pediatrics at Codman said, we've seen a glimpse of something, pediatric integrated care, that better helped us address the needs of our patient population. We need more, and we need it to stick around. We sat across from people who were running health centers. Anita Morris at that time was COO at our largest health center here in Massachusetts, the East Boston Neighborhood Health Center. And she said, gosh, I see we have a need for integrated care, but where I have resources, they're not going there. And where they are going there, they're not going to the pediatric side. We sat across from health system innovators like Megan Bear-Merritt. I remember that first meeting where I said, I think you know something about trauma-informed care. How do we help improve the ability of children in our communities to get trauma-informed care? Just give me the roadmap, Megan. There isn't a roadmap. There were bright lights. There were excellent demonstrations of integrated pediatric care, excellent components of it. John Strauss launched the beautiful McCap program that provided expert consultation to our local pediatricians, but there wasn't an entire system of care for how a roadmap for how to do this. And where we did find parts of this in other parts of the country, they were for a particular population. They were for adolescents with depression or anxiety, or kids in well-resourced communities with ADHD. So the charge that Genevieve and Anita and Megan really brought to the foundations was help us develop a system of coordinated, comprehensive, integrated care. And that's going to take us some time, and that's going to take us some money. So the foundations responded by investing in a couple different ways. One was an early recognition that we were going to be building something. This was not a find it somewhere else, buy it, bring it to Boston. This was a build in Boston. And so in order to do that, we needed to invest in ways in which you build something, which is both an implementation function that allows you to test and invest and get things wrong and figure out what went wrong and then try it again. And to do that in a community of peers, not alone, because it's lonely work and it doesn't work out if you're doing it alone. The other piece was we have to learn along the way, so we have to evaluate what we're doing. And we made a commitment, you'll remember, Genevieve, early on that we said every tiny bit of data that we extract from your health centers, we want to make sure that it is useful and meaningful to you, that you can use it to improve the quality of care that you're delivering, that you can use it to figure out what's going well and what's not going well. We also understood that we had a long range eye on financial sustainability. And so we needed to develop proof points for a public funding environment, for a private payer environment. And so we needed a robust evaluation that included very expensive, tedious analysis like the claims data that had been acknowledged. And we also understood that there were people like Danubia who were like, just give me the data. I need to understand what's happening in my communities. And so Team Up has invested quite heavily in creating public-facing dashboards to indicate how we see, at least in these 7 health centers, children are faring. And in the moment of the pandemic, I venture with a little bit of pride that Team Up had the best data on this in the state of how children were faring in the pandemic based on the data we were collecting, our health centers were collecting on the kids in their practices. So we invested for learning and for development. And part of that was also a real recognition that we couldn't ask Genevieve to step away from her day job to do this unless we paid her. So we bought out a little bit of Genevieve's time. We bought out a little bit of Nancy's time, and we bought out that time, not necessarily to talk to us, but to sit in a room of their peers. There were extensive 2-3 hour sessions monthly for you to make early decisions about what was worth screening about, which screener to use, what was worth tracking, how best to track it. Okay, what happens in our health center when we find a kid or a family that's not doing well? What's the next step? What's working in your health center? What's not? And so we invested in a community of practice for these health centers that were developing this work to talk to each other. And that people like Genevieve and Nancy would also need people at their side to help. So one of the key roles was project management. We put you initially full-time and down to half-time a project manager to be there and help run all these tests of change and understand what was happening live. So I guess I'd say kind of in summary that we knew that if this was actually going to work in the health center, there's a line in that video where Anita says, you can't just take a model off the shelf and give it to a health center and say good luck. We knew that if this was going to work in the health centers and be sustained by the health centers, that it had to be developed by the health centers. And so that's where we put a lot of.
And so I'll have a follow-up question, or I don't know if you want to add anything also, but I wonder if you could say more about sustainability. I mean, both foundations have really made a commitment to sustainability. You mentioned that we want this to stick around. Clearly, we don't want to go into health centers and implement Team Up and put together this great program and have it just shut down when we leave, right? We want this to be sustainable over the long term. So could you say a little bit more about how you've thought about sustainability in the funding decisions also?
Sure. I'll take that on. Shauna touched on all of those, some of the key decisions that actually lead to sustainability. I just wanted to take this moment both to thank everybody from who actually does the work on Team Up for what you do at the FNP-BC, and also to thank the Klarman Family Foundation's partner, the Smith Family Foundation, who, what Shauna didn't say, she was saying the funders made these decisions. I just want to acknowledge that the Klarman Family Foundation joined Team Up in the second phase. And we joined Team Up because of what the foundation, the Klarman Family Foundation's belief in how philanthropy can make a difference is by taking really good ideas and promising ideas, investing in innovation, where ideas that can be a catalyst for change, and having the patience to do it and recognizing it takes a long time to do it. So phase one clearly was not enough. So much was created and co-created. And phase two is where sort of hitting the stride for continuing to prove the model. And the valuation is proving the model. You saw all of those demonstrating that all of those articles that were recently published that are demonstrating the model. You've heard about some policy change that's happening that's going to help sustain it. And so that I wanted to acknowledge that, you know, we came in with believing in what had been built and with an eye towards this idea of sustainability and some key pieces. And so I'm going to pull out just a couple of, in terms of what it means to build towards sustainability within the health centers, just in terms of how they do the work, was investing in some of the infrastructure. So one piece was very specifically investing in an IT analyst who just focused on changes in the EMR, so that would document things that really focused on behavioral health issues, like screening for behavioral health issues, economic and social stressors, just notes that would be there that's both providing the data that's necessary, but also providing the data and building this information into the workflow. So this becomes sort of the standard of practice for how the communication between the team members, and that by building out the EMR, it's something that's laying the groundwork that can be brought to other health centers and sort of build the basis for sustainability in that way. And another piece in terms of the IT analyst that is also helping to just collect the data that supported the process improvements, the ongoing process improvements that lots of folks talked to, others have spoken to, as well as feed data into the evaluation. That's also been critical to help build the case for Team Up and then this model in the future. And then another piece is the focus on revenue optimization. So how do you actually, if you want sustainability, it's both how do you sustain the practice, make it stick in the health centers, but also how are you optimizing revenue so you can pay for some of these clinical positions and other positions that philanthropy is helping to underwrite. And so that in cohort one, so it was supporting a billing champion and to help optimize the revenue. In cohort one, the billing, they were able to increase effective billing to generate sufficient revenue to make a substantial contribution to behavioral health clinicians. So that happened, and that was learned in cohort 1. In cohort 2, the practice of building in this revenue generation and supporting that piece began in the planning phase, so that when the health centers really got up and running, they were just well on the way to maximizing their revenue. And then the final piece, which you will hear much more about, is thinking in terms of like broader systems change. Here is something that is working, and how do we invest? So as funders, how are we investing in bringing this model to light? And what are, and also really pulling on policy levers that will change finance and make something like Team Up more of a standard of care, and one that all of the different pieces, including the very significant piece of the community health workers, are covered through all payment systems.
Thank you. And once again, a perfect segue. Wonderful description. It's like it was planned, but anyway, it's a magic. But Suzanne, you work at Healthcare for All, doing policy work, and we've been very fortunate to have a partnership with you and your organization with Team Up. Could you say a little bit more about how you and Healthcare for All support behavioral health integration at a policy level?
Sure. Thanks, Chris. And I just want to say that we're really grateful to have the opportunity to work with Team Up and with all of you on this. It's been a really great project, and there's obviously a proof of concept here. We're seeing changes on the ground happening, and we wouldn't be able to do this work without support and partnership from the Smith Family Foundation, Klarman Family Foundation, and the Boston Foundation that actually allows my organization to give me the time I need to invest in some of this work and work as a team with all of you. And so for those of you who don't know Healthcare for All, I'll just back up and let you know who we are. We're a consumer health advocacy organization that advocates for health justice in Massachusetts by promoting health equity and ensuring coverage and access for all. That's our mission statement. We do this in 3 ways. I'll just do this very quickly, which is we help people on our multilingual helpline to apply for, enroll in, and troubleshoot health insurance issues. We do community engagement work on a variety of ways of engaging folks, both in our policy work, but also in special projects on the ground that impacts healthcare access issues. And third, we run policy campaigns to affect systemic change. And so that's the piece that I'm going to be speaking about the most, but those other 2 components of our organization and our work are very important to informing the policy work that we do at Healthcare for All on a daily basis. And I don't think we'd be able to really understand kind of like the system as a whole without that. And to the same point, Healthcare for All can't be out advocating without all the other pieces that we've been speaking about around Team Up. Because if there weren't the clinical champions, the people on the ground that were doing the work, well, you know, we can't really show how this is actually happening on the ground. If there weren't the folks who knew and were experts in the clinical model or did the evaluation that showed how this is a proof of concept and why we need this and why integrated care is so important, you know, we wouldn't be able to all be working together and making the case that we need to push the ball forward. So I think Danubia even said in her comments previously and in the previous session that it does take a village. So Healthcare for All, we're really grateful and honored to be named as the advocacy partner, but we don't do this alone. We need a group of child health advocates, and some of whom you've heard in the plenary session, and some of whom you also spoke about some of the opportunities that we have to move this forward to really increase access to behavioral health services for children and families across the Commonwealth. And you know, one of the things we think about when we're thinking about policy work and how this has evolved, that there are windows of opportunity. And right now, I think a lot of them are converging. We have the problem, right, of what we were trying to do, which is having families be able to access readily available behavioral health services in a setting that is right for them in a timely way. And often primary care is very much suited to that, especially in early childhood, but then all throughout the, you know, child and adolescent time, right? And so we knew that wasn't happening across the board. And that is one of the problems that we were trying to do to solve for. And we knew that a lot of primary care practices did not have the resources they need to implement such a thing. And then we, you know, have the policy. So we were thinking about like, how are we going to actually change the system? and then the politics, they all have to kind of come together, and there has to be a will. And I think we're at a time right now where we have really kind of those three kind of windows have kind of converged, and we are beginning to make some progress together. And there's a couple of things that have been, I think, highlighted in the previous plenary about this. And, you know, I will back up to also say that it also takes different strategies. So one of them could be forming coalitions of different stakeholders to come together and talk to policymakers about what's working, what's not, bring data from Team Up. And we've also talked with other integrated care programs as to like why this worked, why this needs to be a priority. There's also more formal opportunities to move things in the state legislature or provide testimony and comments, formal comments. And so I just want to give kind of a couple of examples of how we've worked together to move the ball forward since Team Up has kind of started and have been also thinking more about sustainability in the long term. One, I had talked about how, you know, we're collaborators. We're part of many different coalitions and many different stakeholder groups. You heard before, I think on the plenary, folks were talking about the CAHI, that stands for Child and Adolescent Health Initiative, was started by a group of pediatricians and brought in other stakeholders, multi-sector stakeholders, and three folks on this panel, Dr. Daffrey, Anita and I are on the executive committee. And one of the main goals of that group was to have more of a focus of pediatrics and improving pediatric care in the Mass Health waiver, which I think folks spoke about in the plenary and was explained there, which is not something that historically had been done as much in the past several iterations of Mass Health. So it was a very successful collaboration, I will say, and resulted in some changes around paying differently for primary care, which we're in very early implementation stages. We have to see how this works and continue to work together to give feedback to Mass Health about how it's working or not working and how it can support models like Team Up. And I will say another piece of this too was actually having those roles within Mass Health that are focused on children and families, which did not exist before. So we were very grateful to former Secretary Sutters for that and putting that in. And I think we're really kind of seeing some movement there. Another piece of this is a concrete example that was outside of the waiver, and we worked a lot, I would say, with our early childhood mental health champions is thinking more about promotion and prevention and what can we do on that end of the spectrum to move the ball forward. And part of that is like, how do we support that in primary care? And through some partnerships with Team Up, Healthy Steps, and some other groups that were part of a work group looking at primary care integration, specifically in early childhood, but it's helpful across from early childhood through the spectrum of ages, is we were able to put together a really well-researched memo and like just incessantly talk to Mass Health about, we need to use, we learned about before EPSDT. Well, that EPSDT thing says that prevention is part of it, right? So like we need to use that authority that Mass Health already has to do more prevention work without, you know, necessarily having to slap a diagnosis on a kid, and be able to kind of really bring this more universally to the families that we work with. So one of the ways that we were able to do that is Mass Health did come out with guidance that allowed for coverage and reimbursement for at least 6 behavioral health visits without a diagnosis. And in primary care, it was the most comprehensive. You could do that on an individual level, family level, or group level. And they also allowed that for group visits in community and school-based settings. So for both of the things I talked about that were wins, the waiver piece, and there's many other components to the waiver, which we could spend like 10 million hours talking about, and this preventive behavioral health piece, we know that while there are wins, there are some challenges, like with everything, of implementation, and that's why the implementation piece is important. So you pass something or you get something done, but it's continually, it takes many years, as it was demonstrated too, of even building a model and, you know, having it put in place to figure out how we can increase take up and continue to evolve these different models and wins. And last, I'm just going to say more broadly, Healthcare for All does work with a variety of other stakeholders in the children's mental health and children's health space. including the Children's Mental Health Campaign, which we've discussed with before. We're on the executive committee of that, which includes 5 other organizations looking at the continuum of care. So that campaign is mostly not focused on primary care, but looking at like when kids need specialty care, or there's acute situations, or they're involved in different or need services from different state agencies and have the most trouble getting access to services because there's disagreement between those different agencies about who's going to pay, who's going to provide those services. Is like really like thinking about how can we improve the continuum of care. And I think one of the opportunities we have is to kind of connect this work of the integration with the work of outside the primary care practice, outside the health center, with the whole continuum of care, whether it's at home, school, community-based settings, and clinical settings. So I think that's something that we can kind of look forward to and think about in the future to help kind of not only sustain Team Up, but also make those connections and better serve families.
Thank you, and thank you all for this very rich discussion. Every time I hear from everyone about Team Up, I learn more as well. So I hope this has been useful to everyone. I now find myself in the most unfortunate position of being in between you all and lunch, which no one ever wants to be. It's a little bit after 12:30. I think we got started late. So I think we should probably wrap this up relatively quickly. Yes, I was going to say before we do. So Shauna, but just to make sure that we get around, that we answered the questions also. We had questions about patients' experience and parents' experience. How do we pay for this? What's the secret sauce of Team Up? How do we work with other organizations like TPEC and those sorts of initiatives? And I think a lot of those have been addressed along the way, but I just want to give the panelists a chance to offer another comment. And then if there's clarifying questions from the audience that don't impede too much on lunch, I would certainly welcome those as well.
I would just offer a lunch partner, which is one of the other investments the foundations made together, was to try and get at Sue's question about what is the secret sauce. Team Up is a complicated, multi-factorial initiative. So we, in an effort to document at least early lessons learned, the foundations engaged the Center for the Study of Social Policy and the incredibly excellent Stephanie Doyle, who happens now to be with the Department of Public Health, so she can talk to you and with full disclosure about her work on the report, who authored this wonderful report that goes as far as we knew at the time she wrote it, which is what have we learned early on in terms of how to support pediatric behavioral health integration. So if Stephanie has a chair open next to her during lunch, I recommend that you text her. And of course, the report is also on the Team Up website.
Anyone else from the panel? Or any clarifying questions from the audience? If you don't mind going to the microphone and just introducing yourself.
Yes. Hi, I'm Nellie Burdett. I am the new director of Population Behavioral Health at BMC, about a month in. I'm also the senior lead for CTC, one of the Team Up members for integrated behavioral health. I've been doing the work clinically and operationally for 15 years across the lifespan. I'm wondering, do you have any thoughts or plans on how to expand this model outside of the health centers for the mass health population and then beyond as a model that's payer agnostic? Thank you.
So I will say there is an intentional focus in Team Up that obviously you've heard in lots of different settings around a focus on marginalized communities. One of the ways that we think about that is children who are on mass health, who are served by Medicaid. One of the things that's also important to say there is that part of the reason why that health equity focus is there is to ensure that you create a model that works for historically marginalized communities. That model will work for everyone. There was really excellent research that came out of the vaccination campaign when COVID vaccines became available about how if you start with your most vulnerable, the processes you put in place will work for everyone. So it's not a sacrifice between serving this population or serving that. So we do feel as though like Team Up in health centers is payer agnostic. Everything that Nancy and Genevieve and their teams are doing, they're doing for 100% of the children who are coming in. And the team up health centers actually have variability in the portion of their population that is on Mass Health. So from that perspective, I think the revenue components are agnostic to payer. The other question about kind of expanding outside of the health center, I would actually say that one of the core parts of Team Up is the commitment to ongoing model development, and that is exactly an area that we would like to explore more. There were early on, Genevieve, you'll remember this better than me, but we talked a little bit about ways to bring things like Boston Basics, which is a really, really simple way to kind of ingrain healthy parenting strategies for caregivers, not only into the health center, but also into the early education system, so that every child was getting kind of a similar message. Every caregiver was getting a similar message across the board. We do work with like all community. I think it's true that all of these community health centers work in schools. They have school-based health centers, so already have a school-based presence. But I think there's a lot more opportunity to expand beyond just the walls of primary care.
Thank you. Any other questions or any other comments from the panel? Or just stomachs rumbling? I think I can hear that. So
I think that I actually want to say the secret sauce thing for me, and that despite not having the same robust funding anymore, is our family partner role. Like if you hear of a model that is just going to put psychiatry, just going to put a therapist into a clinic, you should tell them they're wrong. So I'm really serious. Like you should tell them they're wrong, whether they call it a community health worker, whether they call it a family partner, and just Jacko, like, I don't care what the population is. I think if kids are going to receive robust behavioral health care, you have to have a person who is tagged to the family and the parent, and the other team members can't take that on and do that well, just like I couldn't do my clinical job well and do the stuff during the grant until someone took that time out. Like we need to protect someone and compensate them well, pay them for their lived experience to be that person. So just anybody who's creating, like, don't throw that out because it's the cheapest role to get rid of, or the whatever the reason is that gets thrown at you. Fight for that one. Yes.
yeah, and I would say that's one of the strongest themes to come out of the qualitative evaluation that we've done. There seems to be near unanimous, or I'm not even near, I just feel the need to say near. Everyone we've talked to feels the same way, that same level of enthusiasm. It's really overwhelming. So so thank you for making this point.
I'm just going to add on to that. I think that's also been the most challenging with regards to when you're thinking about reimbursement for the primary care practices, some of the non-clinical roles, and understanding just like the value monetarily, but also as like key members of the team is, even we were thinking about expanding like peer supports, even in the adult space, or, CHWs, or, different types of folks that are not clinical. I think that's one of the pieces that we continue to need to work on, I think, at a systemic level as well. And then to the point just about the different payers too, is, looking at some of the wins and pieces that we've had in Mass Health, is there a way that we could at least expand to private health insurance potentially, which is always a difficult mountain to climb and very different. And it comes with its whole host of other kind of challenges, but at least can we start maybe thinking about ways that there might be opportunities to do that as well. For both, I think, when we're thinking about the non-clinical professionals on the team, including community health workers, and when we're thinking about just, the model kind of overall and integrated care.
I just want to say, I think one of the things that has been so wonderful about this has been the level of support we got from the BMC people. And really, when you're on the ground doing the work, having somebody else figure out what the data shows is incredibly helpful. And so we got support from the psychiatrists at BMC, and our meetings were weekly initially, and then every 2 weeks with Anita and her team were really helpful. And then I also want to acknowledge that, our funders were amazing, in that, when we hit the pandemic and they kind of they realized that we were going to have to change things. And allowed us to do it that way. And I think everybody has been so supportive. It really has been a wonderful experience.
Thank you very much. Now, I think we've pushed lunch as far as we possibly can. Two quick things before we as we're going even. If you want more information on the WOVA platform, there is an early learnings case study that provides a good overview of what we discussed today. Of course, you can talk to people on the panel as well. And as you know, lunch is down the corridor. I believe there's poster presentations as well.
Understanding that we wouldn't be able to get every single person here through lunch exactly at the same time, there's a few other things to do to kind of figure out when you want to hop over to the dining hall. There's posters up. There's the interviewing that the video storytelling folks are doing. So take your time. We'll stay up here for a little bit as well, but there's some activities you can do during the lunch hour too. Thank you.
Thank you very much. Wow.